Uh, Good evening, sir. 2-year, 5-month-old male child, third by birth order, born of third degree consanguineous marriage, resident of Mumbai, and hailing from Maharashtra, Muslim by religion, brought by parents with complaint of one episode of paroxysmal event 7 days back on 15 January of 2026 and weakness of right upper and lower limb since 5 days. Then child was HOPI. Child was apparently all right 6 days back. Then child has one episode of trivial fall not associated with vomiting or loss of consciousness. And 6 hours later, child had one episode of the paroxysmal event in form of tightening of both upper and lower limb. It was associated with uprolling of eyes and not associated with deviation of mouth or frothing from mouth. And it was lasted for 2 to 3 minutes, resolved on its own, and it was not associated with any PID. Then child was febrile during this seizure. One day later, mother noticed that there is sudden onset weakness of the right upper and right lower limb. The weakness progressively worsened over next 24 hours. Then prior to the onset of symptom, child was able to lift his hand above the head and hold the object. However, at present he is unable to hold the spoon also. Then movement of the lower limb are markedly reduced compared to the other side. In addition, currently the child is unable to roll over to another side and cannot get up from the supine position and is unable to lift his head. During this time, mother also noticed child was irritable and crying, and he had a deviation of angle of mouth toward the left side, and it was associated with drooling of saliva. Then history of poor appetite and not gaining weight 1 year back, for which child was admitted and rehabilitation done. Child has transfused one PRC in view of low HB, and all investigation done at that time was told to be normal. Uh, then no history of altered sensorium or vomiting, no history of blurring of vision, no history of any involuntary movements, no history of abnormal eye movements, no history suggestive of sensory involvement, no history of hearing impairment. No history of bowel bladder involvement, no history of excessive sweating, no history of inability to close eyes, no history of regurgitation of the feet and difficulty in swallowing, no history of Cox or Cox contact, no history of any bleeding manifestation, no history of cyanosis or recurrent LRTI, no history of fever or neck rigidity, no history of similar such episodes in the past, and no history of decreased urine output or decreased oral intake, no family history of similar complaints. Then past history, history of admission in March 2025 in view of low HB, for which child has required one PRC transfusion. And ANC history registered 5 to 6 ANC scans were done, told to be normal, and mother was non-compliant to the iron folic acid supplementation, and mother has no ANC related complication. Birth history, full term normal vaginal delivery. Baby cried immediately after birth. Birth weight was 2 kg. No history of NICU stay and discharged on day of life 3. Immunization history till 1.5 year of the age. Developmentally, in gross motor, child can run and jump, and he climbs up and down stair with 2 feet per step. In fine motor, he feeds with spoon and remove his own clothes. Then in language, he can speak 50 words, and in social, parallel play is present and he shares toys. So interpretation, he is appropriate, developmentally appropriate for the age. Diet history, exclusively breastfeed till 6 months of the age. Complementary feeding started 6 months onward, and he take predominantly meat-based diet. There is a calorie and protein deficit. Calorie deficit of 470 kilocalorie per day and protein deficit of 6 gram per day.
Okay. Uh, Online audience, just bear with us for 1 minute. Okay. You can hear us, right? Online?
Yes, sir. Yes, sir.
Yeah. Okay. So now uh, you heard the history, 2-year-old with a history of a seizure, right? Paroxysmal event. So what do you make out of that? What is your interpretation of that? Come here, come ahead. There was a trivial fall, right? And then the seizure. So do you think this seizure was due to the fall? What do you think?
Sir, fall was not that significant. And there was no any associated symptom also, no history of vomiting or loss of consciousness.
Okay. So when you get a seizure due to a fall, one is when can you get the seizure? And two, so first tell me when can you get the seizure? Immediate. So you somebody has a fall and immediately has a seizure possible,
It can happen.
but that's known as impact seizure. Okay, it is definitely possible. So that is impact seizure. That is within seconds of the big injury, right? And then you have a seizure later, which is due to raised ICP, which, as you said, is vomiting, headache, all that, right? So could this have been an impact seizure?
Proper 6 hours later, not immediately after the fall.
This seizure. Okay, so all the more reason. If it happened 6 hours later, then it is due to raised ICP.
There are no other signs of raised ICT.
Okay. And how do you judge the severity of the injury? So suppose somebody says that he was running the child and he tripped and fell. And so is that significant or not significant? So how do you judge the severity of the fall? Come on, anything, anybody, any thoughts? So what height? 1 feet. So many children fall from the bed. Very classical. In practice, you will get mother went to the kitchen, baby rolled and fell from the bed. Significant fall or insignificant fall? So what is the height? So 3 feet is the cutoff. So fall more than 3 feet in height is considered significant, but that is one point, not all. Second point,
Nature of the trauma and
yes. So in that, what is important?
is it, if there is a history of head trauma, then it's counter injury or
Agreed. But when you say nature of the trauma means what we mean is there's something known as high velocity injury. So motor vehicle accident is a high velocity injury. So even if there is no 3 feet fall, that high velocity is important. Okay. Then what else is important? To decide whether that injury is significant or not. Excellent. Associated loss of consciousness. So now, how long should this loss of consciousness be? So again, why I'm asking this is many times a child will fall and will look dazed for like 1 or 2 seconds and then is normal. So that 1 or 2 seconds is loss of consciousness or it is not loss of consciousness.
Because of the shock, think of the time. Oh, 5 minutes more than 5.
5 seconds. So loss of consciousness for more than 5 seconds is considered loss of consciousness, right? And so on and so forth. So you said this is not a significant injury. So the seizure is not related to this injury.
Because there was a history of trivial fall, and after that child was normal. There was no associated vomiting, no associated loss of consciousness, and child was active also.
Correct. Now, the second thing you said is later this child had a hemiparesis, right?
One day after, sir, mother has noticed there is a weakness of the right side of the upper limb and lower limb.
So,
One-
could it be that because of that hemiparesis, this child fell?
It can happen, sir. Mother can.
Here in this case. You think he got hemiparesis, so he fell?
Mother might not have noticed it earlier. She noticed it because like trauma became significant life event for that child, and after that noticed. It might be there like थोड़ा सा पहले से.
So I think here we are clear that it's not a traumatic problem. Okay, then if it's not a traumatic problem, then what is this due to? He has been a normal child. He has been a healthy child. He has been absolutely normal prior to the event. And there is no trauma significant. No infection either. You said no fever. Then what happened? What must be the probable cause of such a situation? You know now.
Sir, there has been a blood transfusion before.
So that's why I'm asking what must be the cause? To begin with, forget that transfusion. Okay, then we will relate it. What must have happened? Apparently, neurologically normal child has had no past history of any brain damage. So his brain has been normal. Okay. Was it a provoked or unprovoked seizure?
Unprovoked, sir.
Call it an epilepsy. Definition of unprovoked seizure.
No past history of seizure and no family history of the seizure.
First epileptic seizure. And first member in the family.
So, in other words, sir is asking what is the definition of epilepsy? Besides a seizure, what should be there?
Anyone. Unprovoked, yes. Okay. Moment it is provoked, then you need not consider any epileptic, even though known epilepsy can be also provoked. So, recurrent seizure. Unprovoked recurrent seizure. And what is recurrence? 2 is recurrence. So, usually more than 2. Okay. 2, so you start worrying. But at 3, you call it a recurrent, right? So now, therefore, if you look at a seizure as such, you need to look at whether it's an acute symptomatic seizure, okay, or second, remote symptomatic seizure, or idiopathic. What is acute symptomatic seizure? Any idea?
If there is a history of fall and
Acute symptomatic means there is acute symptoms preceding the cause of pain. So the seizure is due to that acute symptom. Okay, that has caused this seizure. So, for example, a fever, infection, metabolic, whatever. So, this is acute symptomatic, which means even today that trigger is present in that child. So, we need to pick up quickly what that trigger is, and that trigger needs to be controlled. So, that is acute symptomatic. Then, what is remote symptomatic? Remote symptomatic is the brain is already damaged earlier due to whatever reason, and now it is causing a seizure. So why should a previous damage cause a seizure now?
If it's remote symptomatic seizure, and it can be occur due to the SOL space occupying lesions also. Then if that space lesions increases in size and it significantly increases the brain damage, then it can also manifest as a seizure.
The remote symptomatic seizure, we mean damage has already been there in the past, but the epileptogenic focus took time to present. Damage is the cause. Okay. And therefore, somebody may have fallen down badly some months ago, and now he gets a seizure, which means the focus did appear that time, but it was not enough to develop an abnormal electrical discharge. It is called as epileptogenic period in between, and therefore the damage occurs earlier, but the fit because of that may take a long time to manifest. And then the third is idiopathic, acute symptomatic, remote symptomatic, or idiopathic. What is this seizure? We always look at the first seizure in these three ways. Okay. So do you think it's an acute symptomatic? No, the child was absolutely healthy, normal, etc. So that's out. Could it be remote symptomatic, which means the brain is already damaged? Is that a possibility?
So example of remote symptomatic is cerebral palsy. So birth injury, and then that baby gets the first seizure at 6 months or 1 year. This is known as remote symptomatic, right? So what sir was trying to say is injury at birth, then whatever that fibrosis, that damage, gliosis happens, then the electric impulses take a wrong path, and then the seizure starts. So all this process can take 6 months, 9 months, 1 year. So that's your example. So in this case, do you have any such history that there was some problem earlier? No.
But the problem may not be obvious even to a doctor. So no history, yes, but that doesn't rule out that this brain is not damaged. So the next question is, which can be hidden causes, apparently hidden causes, where the brain is damaged, but neither the neonatologist or a pediatrician knew it, and the parents, of course, did not know it. So which are the hidden causes of an existing damage, which obviously may not be very severe, otherwise it would have been noticed. For example, a neonatal seizure is difficult to make out. He's not having tonic-clonic seizure. So something might have been easily missed. So now how will you sure whether it's easily missed or not? In other words, are you sure this child's brain is not damaged?
Child was developmentally appropriate, and there was no history, birth history suggestive of any perinatal asphyxia, or no history, no previous history of seizure, and the activity and sensorium is also normal.
Correct. So all that you said, sir is asking anything that is subtle in the newborn period, which may not have become obvious that time, but might have caused some damage.
A
It will-
1.9 kilo baby, discharge as usual. Everybody thought neonatal period was uneventful. Is there anything possible in such a baby?
Thus giving you a clue. What is a 1.9 kg baby prone to? Prone to at that time, newborn period, prone to
Exclusively breastfed from birth. No top feeds were offered in spite of baby crying all the time first 3 days. If the baby is crying all the time for 3 days, then
Sepsis.
but
What
sepsis
else?
would present in a different way, fever,
look at his hints. He has given you so many hints.
and it is common.
Excellent.
And it is subtle. And we insist on breastfeeding, 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 and the mother doesn't have, but she keeps on breastfeeding, and a subtle hypoglycemic attack may be missed. I'm not saying that you start top feed at that time, but you should be aware of this. And it can be subtle, and everything happened properly. and later, maybe years later, for example, there could be only occipital damage and he may have something which is related to his vision. He may go and he suddenly come back, may look unresponsive, nothing happened.
And acute symptomatic, when you said SOL, actually SOL, if you get a seizure, it's acute symptomatic. Means that problem is now, and because of that, you've got a seizure. So that is acute symptomatic, right?
So now the question is, what points in the history you want to be sure that there was no subtle damage? You said that development is appropriate. Now, what is appropriate needs to be in detail gone into. This is important in this question. Okay. For example, you ask, सब समझता है क्या? हाँ, सब समझता है. Now, what is समझता है? Okay. So, how would you pick up that? A typical hypoglycemic injury may present only with some learning disability. Till then, everybody says you are all right. No, he's not tested to that level. So I'm asking you, how detailed the history can be further taken to pick up some subtle abnormality? Give a thought, doesn't matter. Okay. A typical Nelson's chapter may not give all this. It has given somewhere or the other, but we want to kind of bring them together. So what could happen to a child who is very minimally damaged? How would we look at that child? And could we ask the mother whether she has observed everything?
So what subtle parameters can be there in the early part?
Any thoughts? Anything that you can? In the newborn period, will you ask for something? So you'll ask for the behavior of the baby. How was the baby crying actively for feeds, sleepy, lethargic, extra irritable, all that. So whether the behavior was perfect. And now, which part of the milestones will give you some clue about subtle damage? Will it be motor milestones? Will it be
Social milestones.
okay? So social and cognitive, you will try to get into as much depth as possible, right?
That there was no risk factor at birth, and let me know preterm, etc., cried immediately. But for that, you add one more statement, no evidence of neonatal encephalopathy. Now, what does it mean? He did not behave the way a normal baby at birth behaves. So the question is, how does a normal baby behave at birth, right at birth?
If feeding is present, and after that, after
Sir wants a perfect, accurate account. So baby is out. Okay. First thing that the baby does is cry.
Cries.
After that, start telling sir what.
So cries immediately. What happens next?
tone activity.
Any idea? Cries immediately.
See how we said loss of consciousness for so many seconds. Then we said how high is the fall. So everything has to be as definite as possible. So now cry for how long? 1 minute, 2 minutes, 10 minutes?
No, never stopped crying. Very good, no? Not only cried immediately, but cried a lot for a long time. Is that normal?
No, sir.
So cries immediately and then stops crying. How does he stop crying? All of us must have attended, at least got a sign of attendance in a third MBBS about the delivery attending, right? The child cries immediately and when bonded, stops crying. And how does the bonded? You must have seen the UNICEF video of breast crawl. That's why we say put the baby on the breast even before you cut the cord. And that bonding warmth of the mother, okay, baby realizes that yes, I'm not alone in this world. there is some caretaker, and the baby stops crying. So that, whether that has happened or not. Okay. Now, how long does the baby sleep at that time? Now the mother has bonded, cry has stopped. How long would the baby take before the baby wakes up again? 10 minutes, 20 minutes. Baby sleeps for 2, 3 hours and then wakes up, and at that time shows the hunger and then starts sucking well, sucks for a short time, whatever, stops sucking, gets satisfied, goes to sleep, and the sleep feed rhythm starts over time. This is neonatal behavior. You need to look at that. But we talked about hypoglycemia. The milk starts secreting only after 2, 3 days, no, on the breast. On first day, there is no milk. Then the baby can stay without sugar. And here we are talking about hypoglycemia. That must be the commonest cause. He said common cause is hypoglycemia because we don't give outside feed. We say breastfeed, breastfeed, and the first 2, 3 days there is no milk.
Colostrum, sir.
Colostrum has enough sugar. Colostrum has fat. Where is the sugar coming? And colostrum has not even a volume. That's a small amount, few teaspoons. Okay. So how can the glucose be managed at that time?
Are you going to start off with for every baby, or does the baby have some reserve which the baby has right at birth so it can metabolize that? Yes.
Yes.
So there are reserves in the liver, and the baby has ability to metabolize the fat, and the baby can manage in the initial stage. And if the baby is low birth weight, it doesn't have much liver. Doesn't have much reserves in the liver. It may not have significant amount of fat. Is already, so to say, wrinkled, fatless. So this baby is likely to suffer much more. It doesn't even have that much of the breastfeeding is a act of power. It's an exercise. The baby may not be able to suck so continuously. Gets tired. There is no reserve anywhere. It doesn't take any time for the baby to lose sugar. So that is what. So we have to guard against all that. Tell the mother accordingly. Just keep on feeding, keep on keep on feeding is not the advice which is applicable to all the children.
So diabetic mother, baby will never have hypoglycemia. Plenty of sugar. Correct? Yeah, hyperglycemia. No? Where is the dearth of sugar?
Neonatal hypoglycemia is common.
In diabetic
Diabetic
mother. So sir is saying that because the mother's blood sugar is high, why does the neonate get hypoglycemia?
There is beta cell hypertrophy in the baby because of the excess sugar of the mother.
Insulin production, sir.
Excessive insulin.
So the point is that extra sugar is not coming to the baby. Okay. In fact of that, because there are a lot of hormonal changes, babies are born with large weight. Okay. And therefore, those babies are also likely to be hypoglycemic. So the point that we are making is that we would have asked the details of social and cognitive functions, and something soft science would be seen on examination. Therefore, he always says that developmental history is different than developmental examination. So when we examine, we will pick up something maybe even in this child. Okay. So that so far so good now.
So this discussion was just to see whether this child was perfectly normal or no. We were discussing that. We are coming to the seizure as a remote symptomatic or no. We were answering that, right?
And if it is neither acute symptomatic or remote symptomatic, then shall we call it idiopathic? So you know the definition of idiopathic. The doctor is idiot and the patient is pathetic. That's why idiopathic. Okay. So idiopathic is not accepted. Idiopathic is I don't know. But to parents, we can't say I don't know. So say, what the problem my child has? It's idiopathic. They say we have not heard this disease. So shall we call this idiopathic? Epilepsy is idiopathic. You're born with a focus, but it has manifested for the first time. That has not been seen, and the rest of the brain is normal. So you even did not know. So we should never call it idiopathic at this stage. Idiopathic epilepsy as a suspicion first time is beyond 5 years. Not till then. Till then you have to find a cause. So there has to be a cause.
Sir, next day now the baby has developed hemiparesis.
Yeah. So, but that must be transient, no? Yeah, it would disappear. We have story of only one day developed.
No, sir, but 24 hours onward, there is a weakness of the right upper limb and lower limb, and it has worsened over the days.
So then it is pathological. So what happened that? What is that due to?
It can be due to previous brain injury and that manifested.
Brain injury doesn't manifest as hemiplegia. Hemiplegia is an acute onset problem. Seizure may be.
Hemorrhage.
So first look at it as a bigger, broader entity. So some vascular problem. Okay. In vascular, let's discuss whether it is hemorrhage, thrombosis, or infarction. What do you think? Take each one and just everybody just think. Suppose it is hemorrhage. What will happen?
If it's due to the hemorrhage, then there will be associated signs also, like associated other clinical symptom, such as vomiting or loss of consciousness. In that case, there is no associated symptom like vomiting or loss of consciousness.
So
Then hemorrhage will also present with a catastrophic presentation,
Very
which
good.
will improve
Very
over the
good.
time. So
Very good.
at presentation, it will be worse than then.
Good. Could it be embolism?
Embolism also, yes, sir, it could be, but yes, sir, epileptogenic.
So something more you answered. You answered very well first, hemorrhage. Now give a thought. Could this baby have an embolism? And
The
therefore,
embolism-
embolism will occur only when there is a risk of developing embolism. So tell us, what is the risk of developing embolism? And if that is not there in this child, then embolism is out. So who gets?
Prothrombotic state.
Not embolism,
So
but
where does,
thrombosis.
if it is embolic in anybody, where do the emboli come from?
Heart, like,
Yeah,
and then
absolutely. So whatever the damage to the valve may be infective, maybe whatever. There is no such history. So embolism is out, and embolism is very rare otherwise. Okay, in adults, embolism is common. Pulmonary embolism, any other embolism. So that is out. Could it be thrombosis? So risk factor for thrombosis? Give a thought. So that
You said
we are-
prothrombotic states, you're right. But prothrombotic states is one portion or one sub portion of the all the thrombotic things, and it's not very common. Any other?
Prothrombotic states could be due to dehydration. It can be due to any drug intake, or it can be also, and genetic causes of thrombosis also can
very
be there.
good. Does nephrotic syndrome come with? Okay. And therefore, there is no such risk factor. So the thrombosis also not. But thrombosis could come with some biochemical abnormality which we may not know. And many times, even if we find by investigation may be negative, but we will still consider and we will just observe whether you would get it again. So thrombosis is the commonest cause of vascular injury. Hemorrhage is out, embolism is out. Could it be vasculitis? So how How are you sure whether this is not vasculitis? And what is itis? Inflammation. So is there an evidence of inflammation, fever, some reason? No. Autoimmune? No. And therefore it's not vasculitis. And the only other cause remains is vascular spasm. And in which case do you get vascular spasm? Some metabolic disorders, inborn error of metabolism. Certainly not common, but yes, correct? So rare. So when we do not have other four probabilities, we end up saying that it must be thrombosis. We don't know the cause. We will decide whether we want to investigate. So this thrombosis, but decide at lost consciousness?
At the time of, no.
No. So how is that possible? Some big area of the brain, almost an MCA. Okay, hemiplegia, maybe dense hemiplegia, severe illness. Okay, and middle cerebral artery supplying a good lot of area. Why is he not unconscious? He has an intracranial problem, no? And one major artery. And even then, no unconsciousness. So the question is, which part of the brain should be involved to get the patient unconscious?
Consciousness is maintained by what? Reticular activating system.
Brainstem.
Very-
This is not brainstem. This is only the cortex. So can a cortical problem cause unconsciousness? And the answer is yes, bilateral extensive cortical damage, not localized. So this is not likely to happen, and therefore we are happy there is no loss. But could an infarct cause loss of consciousness? This infarct has not. What is the difference between venous infarct and arterial infarct?
It is in fact will deprive of the brain of oxygen, but venous won't cause so much hypoxia. The damage will be comparatively less. So I think in arterial there will be loss of consciousness.
Okay. We'll give you another hint. Suppose an artery is blocked and suppose a vein is blocked. What happens distal to that area?
Or if an artery is blocked, you will get whatever region is supplied by the artery, there will be severe damage to that area. But if a vein, the outflow is blocked, so you will get signs of raised ICP and
Excellent.
cerebral edema and
Excellent.
all that features.
So in venous infarct, there is a backflow and it's not drained. So large amount of cortex is involved. And as he rightly said, in an arterial thing, it's only that area involved, nothing else. And therefore, venous infarct could present with change in sensorium, but arterial infarct won't. Right? So this must be without causes. So everything fits in, right?
So, Dr. Mohite, one of our teachers who is online, he has just kind of clarified in proper words that diabetic mother sugar passes to baby easily. So, antenatally, baby is hyperglycemic, which triggers hyperinsulinemia in the baby. Post birth, this sugar which was coming from the mother is suddenly stopped, and the baby is still in a hyperinsulinemic state. So, it becomes hypoglycemic, right? And here he said that because this is subacute progressive hemiparesis, whether the anatomy is supracapsular. If the hemiparesis has occurred over 24 hours, you are saying?
Matlab, firstly seizure occurred. After that, after 24 hours, the mother noticed there is a weakness of the right upper limb and lower limb, and then that weakness worsened over the days, abhi 5-6 days.
Over 5-6 days, each day weakness is worsening.
Sir, currently child is admitted in ward, and over these 5-6 days, that weakness is worsening, increasing.
Well, I think that history we need to check because that's unlikely that an obstruction keeps on improving, increasing over time. What she has said is she saw it happening more often. So first she looked at the hand and she said yes, but then she also said this is not moving. And then she said, oh, it is even not moving at all. So the degree of loss of power must have slowly increased. That's why she said, and that's why you said that hemiplegia was increasing. By increasing, we mean the degree was increasingly known. Okay. So it's one time effect over, but it's over time, which also favors the thrombosis typically. Right? So far so good. But my question before you tell us the clinical examination, first 2-3 days, then where is the glucose coming to the baby? And where is the fluid coming to the baby? The baby should be dehydrated. You don't take any fluids for 24 hours, you are dehydrated. How can a newborn stay for 2 days with a teaspoon or two of some colostrum? Do any idea? You must answer. Give a thought. I will give you a simile. Uh, I did not earn any money at all today, and not for next 2-3 days. Will I starve and die of starvation? Why not?
Baby has some reserves.
So have a balance. So does the baby have a balance?
Brown fat is there.
Baby has a balance for first 48 hours. That's why you don't need to give even a drop of water. That's why baby is born with excess and the babies lose weight over 4 or 5 days because by then the nature has started breastfeeding. So look at the way the nature has made it, isn't it? Nature knew science first and then organized the thing, and now we correlate it with that. Yes, it must be so. So that's why I said, fine. Yeah.
Okay, now quickly, in the earlier history, you said about a year back, this baby got a blood transfusion, right? That time baby was having poor appetite, you said. So now Khare sir had brought this up. So in relation to this hemiplegia, what are your thoughts about the blood transfusion? Any connections, anything that you can think, include, exclude? So any hematological causes of hemiplegia?
Sickle.
Sickle cell, very good. Now take it further. So would a sickle cell need a blood transfusion at that age of 1 year? Unlikely, unless it's a crisis. And there was no history or symptoms suggestive of a crisis at that time, right? Then in the diet history, you said it was exclusively breastfed for 6 months and then predominantly milk-based diet. So what is most likely anemia at that point when this baby was transfused?
Nutritional.
Nutritional or iron deficiency anemia plus minus B12, right? So though sickle cell is a cause under your theoretical list of causes of hemiplegia, but here that is not at the top of your list just because of that blood transfusion thing, right? Okay. Nothing else in the history.
Talking about blood transfusion and complication. Suppose you see a child who is severely dehydrated and also anemic. Would you give a blood transfusion? Axial transfusion, severe anemia. Dehydration may not kill him immediately, but his blood is so low, hemoglobin is so low. So would you give blood first or fluid first or both together from two different sites? You had said the causes of thrombosis. Now relate to this.
Give fluid first,
Absolutely.
and that too in a limited amount. Maybe in failure also, if he has severe anemia, so we can't give too much
Very
fluid also.
good. Just similarly, in a diabetic coma, okay, when would you give potassium? Again, fluids first, insulin first, then. So I think that is the cause in our situation if blood transfusion was given when there was a severe dehydration. But here there is nothing of that kind. So that's the only time somebody may get into some trouble, but not otherwise. Right?
So I had a doubt. If you give blood transfusion in a severely dehydrated patient, it increases the risk of the stroke or something like that.
At that point, because so of course it depends on the age of the child, and it also depends on the anemia, which must be usually chronic. Otherwise, it would be acute anemia would be due to blood loss or hemolysis or whatever. But it is dehydration, as you said, is a hypercoagulable state. So obviously, you have to give fluids first, like you rightly said, in a controlled manner, not 20 ml per kg bolus, and then judge, right? In general, in a chronic anemia, you are never in a hurry to transfuse, however low the hemoglobin. Yeah.
This child must have received iron. Okay, because he's pale. And because iron did not work, the hemoglobin further went down, and therefore he got a transfusion. Which other deficiency can be easily missed? Iron is the first thing we give to every anemic child nutritionally. Which other deficiency is often missed? And transfusion is given, and after 3-4 months, he will come again with low hemoglobin, at which time you say, oh, he's again so hemolytic anemic. B12. B12 is often missed. Okay. And first you give iron, and then you say, no, continue for a while, change the brand, see whether absorption is occurring or not, and you forget the B12. And how would you have not missed the B12 deficiency when you did a CBC,
Macrocytosis.
MCV? Okay, but both are there, no? Iron and B12. So one reduces, one increases, then how would you know?
It may be normal. Cytic
Hmm.
also. And
Fine.
you get a
So,
PS,
very good. Very good.
dimorphic peak.
Yeah, good.
Dr. Mohite has added that iron deficiency is a risk factor for cerebral stroke. We know that. And severe dehydration would actually slightly raise the hemoglobin wrongly. So, whatever severe anemia you see is actually worse than that reading which you are seeing, right? Fine. Come now, give us your visual diagnosis and examination findings. The baby is here, child is here, no, no?
Actually, sir, today morning, child has one episode of seizure and sensorium altered since today morning, 1/3. Uh, 2 year, 5 month old male child. 2 year, 5 month old male child, third by birth order and born of third degree consanguineous marriage, birth and developmentally normal and brought with complaint of seizure and acute progressive right hemiparesis with the right UMN facial nerve palsy is a case of ischemic stroke. To rule out vasculitis and my second differential is space occupying lesions.
So, 1 minute. So, just tell us why you thought of space occupying lesion. Just give us a reason.
Sir, space occupying lesions because uh, if there is a history of seizure and in case of the space occupying lesion, the clinical it can manifest as a seizure also, and there is to rule out other causes of seizure, there is no other causes that manifest as a seizure in this child. And, there is
So,
the history of hemiparesis.
so actually, see, if you really your history is correct that the hemiparesis has slowly progressed over days, then only in that rare situation that makes a SOL a little more likely. However, that is also very uncommon in children, right? But not because of the seizure. Okay. And ultimately, SOL, depending on its location, has to cause other symptoms also, no? Like symptoms of raised ICP or other neurological deficits, whatever. To cause a hemiplegia, where should a SOL be? Where should a SOL be to cause a hemiplegia? It can't be cortex because it's too huge a area. Even such a huge SOL will not cause hemiplegia first. So then where should the SOL be? Somewhere where the fibers are closer and it is compressing the fibers from one side or whatever, which is a very, I mean, it's not a very common situation in pediatrics, right? So,
And when it's subcortical, there are many others. There is a basal ganglia there, limbic system is there. So that is out of question. But tuberculoma or neurosis tricercus presents with a seizure in an apparently normal child. That's an SOL. We don't call it SOL, but yes, it is. We have seen that. And we fight between tuberculoma and neurosis tricercus, and many times we don't know which one. So it does cause a seizure. Then why is he saying it will not cause a seizure? It's an SOL only, no?
Uh, child actually, child has one history of admission in the past, and
Tuberculoma occurs often without any history, apparently. Okay. And same way neurosis tricercus. So that's not the reason. Okay. So the point is, it's such a small lesion that it only causes a focal seizure. This is not focal. It's causing a hemiplegia and progression. And therefore, the point is, in typical SOLs, supratentorial always would have some more involvement. Okay, where and infratentorial tumors do not have a seizure. So seizure is out. We should not keep that at all in this shell. Okay.
SOL is out.
Okay. SOL is out. And I think in an exam, you will be in trouble if you defend SOL. Because SOL is out here. Okay. There's no reason. So then you said vasculitis. But we just now talked that where is the itis part? So why do you say vasculitis? You could have said, and therefore today the neurologists call it as arteriopathy. When we don't know, we use a complex words, look very impressive. Okay, some arteries are pathological, so we call it arteriopathy. But that is an accepted word. So one in an exam could say it's some kind of arteriopathy. Well, I don't know whether it's a thrombosis, maybe that's all. That's the way it is, right?
on examination, child was conscious, awake, febrile. Heart rate was 110 per minute, regular, normal in volume, equal on both sides. RR was 28 per minute. Saturation was maintained on room air. Peripheral pulses well felt. BP was 88 by 56 mmHg, which is at 50th centile. And then HGT was 130 mg per dl. Pallor was present. Bilateral multiple cervical lymph node palpable, and no cyanosis, clubbing, icterus, edema. Anthropometrically, weight is 10 kg. Anthropometrically, child is moderate acute malnutrition. And then on head to toe examination, weight is 10 kg, and height is 76 centimeter. Head circumference is 46 centimeter. Mid upper arm circumference is 13 centimeter. And weight for height falls between -3 to -2 standard deviation. Though impression moderate acute malnutrition anthropometrically. Hmm. Sir, 2 kg.
76 centimeters the height of a, or length of a, not height, of what age child?
Sir, he is 2 year 5 months old.
So what do you think the length is appropriate for 2.5 years? When is 76 achieved?
On birth, it's 50 centimeter, and then within
So if it's a tall baby, then maybe 74, 75 max at 1 year. But if he's 76, it could be 1.5 year or so. So if his height age is somewhere around 18 months, then how would you interpret 10 kg for an 18-month baby?
nutritional.
What sir is asking is that you have to always try to correlate your weight with your height. So, sir is asking at 10 kgs good weight or normal weight at what age? 1 year? In a baby who's born full term normal weight? Otherwise, little more than. This baby was 2 kg at birth. It could be even 1 year, 3 months or something, 10 kg, right? Or 1 year, 6 months. And what weight, what age is 76 centimeter normal? Again, 1 year,
And
so
little more.
little more. So what we are just trying to say that upfront the 10 kg and the 76 centimeter look almost similar to the age, like the same age. Okay. Now, any baby who has undergone malnutrition, weight will be affected more than height. Right? So when weight is not affected more than height, just think again and check again whether this is really malnutrition or it is constitutional. That is the point that we are trying to explain.
When weight is not affected, but the length is poor, no? Though proportionate, would you look for a short stature in this? And that could be rickets. And now you have a hypocalcemic seizure. So we move again out of this. So do you think this is a short stature?
76
Because
centimeter.
76 seizure is 15 months and he's 2.5 years. Very short. So you must examine for short. Okay.
Sir, height is
Would you look at for short stature in this child?
Sir is asking, will you investigate or start analyzing him for short stature? What's your answer?
height is affected in chronic malnutrition.
That's why the question, when you said it is moderate acute malnutrition. So first there has to be malnutrition and secondly acute. The word severe acute malnutrition, moderate acute are sometimes not appropriate.
You will think of short stature when only height is affected. When weight is affected, the topic doesn't arise. You can't separate the two, right? So when only height is affected and weight is normal, then you will think of short stature.
So this child may be appropriate, his weight may be appropriate for his length. And when he is little small, you'll also look at the parents and see how they are. Mother is 4'10", father is 5'2".
Weight for height, you have said -2 to -3 looks not normal. Weight for height is normal in this child.
Head to toe examination and skull anterior frontal closed and frontal bossing present. Face no facial dysmorphism. Chest and abdomen normal. Back and spine normal. And then extremities, there is a bleb secondary to the IV extravasation and external genitalia appears normal. Then on systemic examination, CNS, child is alert, not interested in surrounding. GCS is 14/15. Then cranial nerve, first is intact. Second, fixing and following present. Bilateral pupil, equally reactive to light. Then third, fourth, and sixth cranial nerve, normal. Eyeball moves equally in all direction. Then fifth cranial nerve is also normal.
1 minute, go back. See now, when you say child is alert and not interested in surrounding, what do you mean to say? What do you want to say?
Child was awake, sir, but he was irritable, and not he was crying continuously. He was irritable, and
Yeah, so maybe you should not write the words not interested in surrounding. Because see, if you are saying that child is alert and you are giving a GCS of 14/15 and then saying not interested, it means something different. It means either the child is apathetic, so severe protein malnutrition, or whether the child is autistic. It starts giving those connotations,
he
right?
was irritable.
So use the word irritable. Child is alert, irritable. Okay?
And when irritable is not expected to be interested in surroundings.
Sir is saying anybody who is irritable will not be interested in surrounding, no?
Mm.
But by saying this, you are inviting 2 or 3 questions which you will have to answer rightly. Which GCS normal person is not interested in surrounding?
He was irritable only. And 7 cranial nerve deviation of the angle of the mouth to the left side, and child was able to close his eyes, and there is loss of nasolabial fold on the right side. Other cranial nerves normal. Then on motor examination, child is lying in supine position. Bulk
So
of
how did you see whether the child was able to close the eye or no?
sir, while sleeping close the he can able to close the eyes, both the eyes. Then while examining the cranial nerve to look for the 7th nerve uh, eyes function, then we there will be resistant to opening of the eyes when closed.
Sir is asking, in this child, 2-year-old, were you able to tell him close dole meet zorane and all that? Was he able to do all that?
No, we
So then one answer you gave is that when he was sleeping, his eyes were properly closed. That was one answer.
All that you would have said it, what you mean is no ptosis nor inability to close the eyes. So you call it normal.
She is differentiating between lower motor neuron and upper motor neuron.
We are just not pointing out faults, we are just making observations.
uh, Then on motor examination, bulk of the muscle is bilaterally symmetrical. Tone on the right side, tone increased in upper limb and lower limb also. And on left side, it's decreased in upper limb and lower limb. Then power is more than 3 by 5 in all 4 limbs, and reflexes. Plantar is bilaterally extensor and deep tendon reflexes. Knee reflex is brisk on right side and left side also. Ankle reflex is also brisk on right side and left side. Then triceps is brisk on left side. Biceps is also brisk on left side, and supinator reflex is 2 plus. On sensory examination, pain sensation is intact. No cerebellar sign and no meningeal sign. Other system, CVS S1 S2 normal, no murmur. On RES, ear entry was bilaterally equal and clear. On parabdo examination, soft, non-tender. Liver was 2 centimeter, palpable below the RCM, and liver span was 10 centimeter. Spleen is 1 centimeter palpable. 2-year, 5-month-old male child, birth and developmentally normal, presented with seizure with acute onset progressive right hemiparesis with right UMN facial palsy without any other cranial nerve involvement, without signs of raised ICT with cervical lymphadenopathy, is probably a case of ischemic stroke. To rule out vasculitis secondary to the infective etiology or space occupying lesion to rule out tuberculoma.
What do you make out of the hepatosplenomegaly here? You said both, no? Liver span also you said increased. So how do you think correlate that?
Liver is 2 centimeter.
But span you said is 10
10
centimeters.
centimeters.
So that is increased. And spleen also.
Centimeter pulse.
So do you think this is a hemolytic anemia? Can it be sickle cell now?
No, sir.
Why not?
Also, there is only one time history of the blood transfusion, and child was otherwise normal, not lethargic, and no recurrent transfusion also.
Sickle cell does not need recurrent transfusion.
But there was no sickle crisis presentation.
So how else will you explain the liver spleen? Possibilities. You have to think of something, no? When you said vasculitis secondary to infective etiology, are you thinking of disseminated tuberculosis?
Yes, sir. Cervical lymphadenopathy is present in child. Bilateral cervical lymph node palpable. Possibility of tuberculosis is present.
Theoretically, yes, but then practically, how would disseminated tuberculosis present? Will it come yesterday normal, today seizure, and tomorrow hemiplegia? Will that be the presentation of a disseminated tuberculosis?
No, sir. Not acute presentation.
So
It
we'll
might
have
be
to,
chronic.
yeah. So
Prolonged fever, not doing well,
Yeah.
nutritionally going down.
So in this child, there was a history of poor weight gain present.
but that was 1 year back also, no? So you can't have disseminated tuberculosis from 1 year, no? That poor weight gain of that time. What I mean is again same thing that we've been teaching you all that you must get into little more detail of how normal this child was just before this illness started. That is very important both ways. If normal also and if not normal also.
Disseminated tuberculosis is because of poor immunity. Okay. And the tuberculous meningitis or vasculitis is a good immunity. So two things are a bit different. Bilateral cervical lymph nodes, were they very much specific or small? I think saying bilateral cervical, you should have said more than a centimeter, etc., firm, whatever. So that has mattered. So that alone does not put you to TB. The question is, how do you put liver and spleen together? First and foremost, in this situation, I would not have expected it. Okay. So now I'll give you an alternative. Could it be simply that the upper border that you have looked at has been correctly done? So, because 10 centimeters is too huge a liver. Is the liver firm, hard, or soft?
Was soft, sir.
Soft. Soft is almost never enlarged. Enlarged liver means there is something occupying there. It doesn't remain soft. And to that extent, age is also possibly changed by then. So look at all this, and therefore, suppose by chance in the examination this case comes to you, you should have said liver span normal. Examiner is unlikely to take the liver span. But a person who is coming after you on the same case, they will ask, what is the liver span? The previous girl had said 10 centimeters. We cannot explain that so easily unless we separate the two to some extent. But when liver and spleen comes up with certain neurological complication, it can only be a slowly increasing hepatosplenomegaly, like any storage, but that doesn't come with a vascular thing. For example, typical Gaucher's will come with spleen first, then liver, will also have a neurological problem, but not the neurological problem localized to an MCA. And therefore, I think tuberculous vasculitis doesn't fit in at all. We'll call it an arteriopathy of whatever etiology and should stay with it. Uh, I'm sure you have ruled out TB, but
We have done investigation.
So when you are saying second again space occupying lesion tuberculoma, so again, like we discussed earlier, we have to means understand that is it the tuberculoma which is causing the hemiplegia, or it is a tuberculoma or like a multiple tuberculoma, some causing a seizure. So what I mean is we discussed earlier that tuberculoma by pressure causing a hemiplegia is a very unusual event, and that site also has to be such that it can compress on it and cause hemiplegia. You understood?
We have done investigation for the child. MRI suggestive of multiple discrete and few conglomerated ring enhancing lesion not showing restricted diffusion on blooming on SW1 are noted in the cortical and subcortical white matter of the bilateral hyparietal parapulsine region and bilateral occipital lobe. Largest measuring size is 2.2 into 2.2 centimeter in right medial occipital lobe, suggestive of infective granuloma, likely tuberculomas. This lesion shows target appearance with central T1 hyperintense and T2 hypointense area with hyperintense rim, suggestive of caseous necrosis or liquefaction. Then T2 heterogeneous hypertense non-enhancing area showing restricted diffusion with corresponding low ADC and no blooming on SW1 are noted involving the left thalamus, left occipital lobe and left half of the midbrain and few foci in the left cerebellar hemisphere suggestive of acute vasculitic infection. And there is leptomeningeal enhancement also with enhancing basal exudate are noted involving the cisterns and the cerebellar vermis suggestive of the meningitis. We have done CT brain also for trauma purpose because child has a history of fall. Then in that there is a 2.5 into 2.6 centimeter sized isodense to hypodense well-defined lesion in the central focus of the calcification with surrounding hypodensity suggestive of edema noted in the right parietal lesion. And then another similar morphology lesion of size 1.5 into 1.4 centimeter is noted in the left occipital region. And there is a midline shift also present. USG local lymph node suggestive of the cervical lymphadenopathy, necrotic lymph node present. And we have done lumbar puncture for the child. Then TLC is 120 cell per mm cube and poly is 25%, lympho is 80%, protein is 130 and sugar is 33 mg per dl.
No, sir. Protein
120.
is
Protein is 130.
and sugar
is
33 and 120 cells.
120 cells. Poly is 25% and lympho is 80%.
I feel there is no doubt that there is a disseminated neurological disease. That's one. Is the lung also involved?
No, sir. Ear entry was.
That's, I think, a point against TB. So this looks like a miliary kind of liver spleen disseminated. But then you would have had, so here multiple areas are involved, but no lung at all. Where is this coming from then? Okay. So to my mind, there are few things that we may have to look at some other type of infection which is doing this, which is silent, which is reasonably acute. But then there is no history whatsoever. So the question is, could a latent infection suddenly manifest like this, which also is unusual because he would have had some failure to thrive. So to that extent, we do not know that. The next question then is that there is some CSF inflammation. Okay. And there is a disseminated lesion like this, but not the miliary lesions. The lungs are normal. And therefore, the question is what other etiologies we may consider at all. I'm not sure whether we could consider any other etiology other than infection. Now, what could be the other than infection such etiologies? One is the mitochondrial disorders, which involve, of course, the muscles, liver, brain, all over. And I'm not sure whether such a disease could also cause a meningeal inflammation. I'm not sure about that. We'll look at it. But one such disease which has a disseminated everywhere could be a mitochondrial disorder, which comes up acutely. Okay. And therefore, we will call it infective because that's the commonest way. But here, there is no kind of evidence of any kind in the history. And to that extent, look, how is the baby now? Fine otherwise?
No, sir. In morning, child has one episode of seizure and sensorium is worsened, sir, since morning.
Only a seizure. But before that, again, the baby was okay, feeding well. No. Now that's again unusual. Okay. We don't know. It could be with today we see TB in various different forms. I'm sure, Mahesh, are you on the line? We would like your opinion if possible.
Birth weight was 2 kg. Mahesh, you want to speak? Sir is, you want to unmute Mahesh? Mahesh, unmute.
Yeah, and there, and there.
Yeah. Yeah.
There is some discrepancy between the history provided and subsequent findings you got. This child had a trivial fall, and I think seizure was after 6 hours, uh, and had progressive hemiplegia as they informed us. It's not one time, it was progressive. That's one thing. And I want to know how was the sensorium apart from losing weakness? How was the sensorium? Was it also deteriorating progressively, or now you are changing it? So I need to have the time related correlation of these events. The weakness and sensorium, was it going down hand in hand, or you had weakness followed by sensorium loss?
So I was going to ask the same thing. You said that this child was irritable on your examination. This you're talking of 6 days. Child is here for 6 days, no? So this was in the beginning, or it is now, or all these 6 days?
Beginning on admission, child was irritable. After
So
that,
that probably was a meningitis, meningeal irritation, definitely there at that point of time. Then the hemiplegia, what you said is progressive. That's what you tried to tell us. Am I right?
yes,
The
sir,
weakness which was getting more and more dense as the time progressed.
the previously child was able to hold his hand above the level of the head and he was able to hold the things. Currently, he is not able to hold his
So,
hand above the head and he is not able to hold things. And there is a significant decreased movement of the left side.
No,
so
agreed. Previously means, see, we should be a little more accurate. So previously means before the event, or in these 6 days, means after admission also he was able to raise his hand, but now he is able to not raise. Are you saying that?
Sir, 6 days back he has a episode of seizure, and after that, one day after, child mother noticed that there is weakness of the right and right upper and lower limb, and as per mother, in this 6 week, this weakness is increasing. Like she was saying, there was some movement in legs 2-3 days back, and now there is no
Fine.
movement.
And what is happening to the sensorium in these 6 days?
Sir, on admission, child was irritable, and sensorium is child is thoda lethargic. But since today morning, sensorium is worsened.
So, but
Rajesh,
in,
can I make a comment here, Rajesh?
yes, Mahesh.
Yeah. So basically, we are looking at one etiology with two pathologies. So
That's
TB is an
exactly what I
etiology.
said before she gave the
Uh,
final diagnosis. You are absolutely right.
yes.
We discussed that a SOL by virtue of pressure causing hemiplegia is out of question. And even here, whatever imaging findings she has given, there are multiple lesions, but none of them can cause the hemiplegia. And you have
Perfect.
also given evidence of vasculitis on the MRI. So the
Absolutely.
seizure was caused by a tuberculoma and the
Perfect.
hemiplegia was caused by a vasculitis. This looks something like that. And there
And
is
irritation by meningitis.
sorry?
And irritation by meningitis.
Yes, yes. That's what it looks like. Two different pathologies. Etiology is same, two pathologies. But what all of us means, our concepts are that one lesion cannot, just become big enough and cause a progressive hemiplegia. That is
Perfect.
what all of us have been saying right from the beginning, right?
Perfect.
not
Perfect.
focal.
Yes, sir, it was generalized.
That means bilateral involvement was there with one focus. And sir, in this child has never been ill at all. Thinking of an old problem which is going on for such a long time. This child, if we had seen one day before
Sir,
he had an
one is
event,
that we will have to
I would have
cross
thought
check
it's a
that
normal child.
history. As in, the way you and I take that history of absolutely all right. We will have to cross
You know,
check that history.
cannot present.
I think two things are clear that after the first seizure, the child was feeding also, right? Now, if it is an extensive tuberculous meningitis, how can the child and TB meningitis who is conscious is stage 1? Okay. And all that he has is just a meningeal sign. This child has an extensive TB. Now, how can he be feeding well, alert, till he gets another seizure? Okay, so I think looks very unusual, but we'll be open because we have seen TB fooling us all the time, but it can't be fooling us all the time, all the way. So I think we need to be little careful about what it is. Uh, I think, see, our problem in this Thursday clinic is we never know what has happened subsequently. Because the next time different students come and nobody knows what has happened. So we have lost the important way of learning. Why is that happening? We have been requesting that if you cannot come next time, please tell your colleague to give any information to us. No? But that has not happened even once, not even once. So it's a request. Otherwise, we keep on haggling like this. I know that medicine is not so easy, but if we come to a conclusion, we would have learned something beyond what we know. And I think we are looking for it all. Uh, Disseminated TB like this, presenting with seizure, is almost getting into a stage 2, and in stage 3, he will get a coma. Okay, so he has been alert and feeding well. 2.5 years, he would have gone down fast. But anyway, we are open
You
to all
sent
this.
the CSF for gene expert and all that. It's awaited.
But gene expert is poor for
Yeah, yeah.
CSF. So again,
And
I think you must do a bronchoalveolar
Pulmonary.
lavage.
Yeah, pulmonary also.
Yeah, pulmonary.
GL for AFB, gastric lavage for AFB, do all that. Okay, search for AFB, microbiological diagnosis, right? And yeah, you started ATT on this child.
With steroids.
Yeah, predni. Yeah.
And when did you start this treatment?
6 days back, child has admitted.
So is the child better now?
Sir, no, since morning sensorium is worsened of the child.
So he's worsening now.
Small child with TBM, this is possible.
Funny is, after first seizure, he remains alert and feeding well. I thought tuberculous vasculitis is already a disseminated immune response occurring. And to that extent, looks difficult. But anyway, we would be happy to know correctly what has happened. Okay, and please take it seriously. We must know after a week to whatever has happened to this patient, whether you have come to a conclusion or not. Yeah?
Do you all remember we had a child who had hematuria and multiple TIAs and also neurological event, and we said vasospasm and all. Then you said MRI was awaited. What happened in that child ultimately? Anybody knows? Okay, anyway. Fine. So today's second case.
Hello.
We took more time in the first case, so the non-important parts you can skip.
Archana, 8-year-old female child, second by birth order, born out of third degree consanguineous marriage, Hindu by religion, Adivasi by community, resident and hailing from Vasin, brought by and informed by mother. The child had chief complaints of multiple lesions over the face and the body since 20 days. The patient was apparently all right 20 days back when she started developing skin lesions, which were acute in onset, appearing first within the oral cavity, were blister like, and on bursting, healed with immediate scab formation. The rash progressed to face, followed by neck, trunk, upper limbs, and lower limbs over 5 to 6 days. The skin lesions appeared as scabs, and no blister formation was involved. So, in the mouth, there were blisters initially, but over the body, directly scab formation occurred. The blisters within the oral cavity were pinhead size initially and burst immediately within hours and healed with scab formation. Child had associated pain while swallowing. The rash was associated with 2 to 3 fever spikes per day, which were low grade, documented 100-degree Fahrenheit, gradually reducing over the 5 to 6 days, relieving temporarily on medication and not associated with rigors or chills. And child was active during the interfebrile period. For the above complaints, child was admitted in an outside hospital for 2 weeks, given some IV medications and local application medications. On further inquiry, mother complained that the child had history of bilateral periorbital swelling, seen more during morning and relieved as the day passed by. The swelling resolved as the rash started to resolve after starting the treatment. There was history of hair loss and weight loss present in the child. The child was evaluated at the outside hospital and diagnosed to have some kidney related issue and referred to Sion Hospital for further management and investigations. There was no history of blood in urine, reduced urine output, or frothy urine, no history of photosensitivity, no history of blood transfusions, no history of any insect bite or thorn prick, no history of the joint pains or rash involving the genitalia. The child had history of one admission 1 month back for dengue fever, and the child was admitted for 7 days. The rest of the history is not.
Whatever is normal, you skip.
The consanguinity is there.
There is consanguinity.
3rd-degree consanguinity. History mainly fever.
Child is not here. Is here. Okay. Give your provisional diagnosis, then let's see.
8-year-old female child with history of multiple skin lesions over body and face, which involved the malar area, associated with fever, with history of periorbital puffiness, weight loss, and hair loss, is probably a case of SLE.
Yeah. So actually, see the thing while presenting. What was that rash according to you? The one which started in the mouth, oral cavity, and then on the skin, it directly came as scabs, you are saying. What was that? Means what I'm trying to ask is that rash a integral part of SLE?
The main complaint of the child was rash for which the child presented, and then
Agreed. But then you mentioned history of alopecia and weight loss in the passing. They are very big complaints, na? Alopecia and weight loss. So you should have described that alopecia when, over what time, etc. Then weight loss over what time. That and the periorbital puffiness, it is easy to club everything and come to a diagnosis of SLE clinically. What I'm trying to say is the rash is the illness which brought the child here just now, but the rash is not leading you to the diagnosis of SLE. Understood what I'm saying? Is I am still not clear what the rash is, but if you are saying that it straight away started with crusting or scab formation, it looks more like some infection on the skin. It's a infective disease, right? And the underground or background disease of SLE is there, for which that alopecia, weight loss, and all that is important, right? Okay.
everything has happened within those 20 days period.
Alopecia also that much, weight loss also that much.
She has chronic malnutrition. She is severely thin, but weight loss is present initially also. But the
Closer.
hair loss component is right now. Edema also. But malnutrition is there since beginning only.
And edema is since these 20 days, periorbital puffiness. But you said no, earlier there was some kidney disease or something.
For these complaints, she was taken to outside hospital, and there they investigated her, and for further management, they have shifted the child here.
Okay.
इकडे घेऊन या. Okay, very good. Severe pain during swallowing, but no itching was present over the skin.
I think all this has happened in just 2 weeks' time. That is one thing important. And the skin rash looks more like disseminated some injury, which is likely to be infection because it's crusting and leaving behind some pigmented areas. Even a scalp seems to be involved. Okay, involved all over to that extent. Now, हे केस आत्ताच कमी झाले का? Okay. And therefore, it has involved also the scalp to that extent. So, loss of hair could be a scalp involvement as much. So, entire skin is involved, and there is no other clinical history to suggest that it's other disseminated autoimmune disorder. The skin rash could be. Okay. तोंडाने खाते का आता काही? So again, the so-called glossitis, etc., looks to be a minor issue, and it has already gone through. There is no itching. There is a lot of pigmentation also. There is a lot of pigmentation also. Okay. And yes, and while the rashes in SLE or any autoimmune disorders could be variable, this again, the fever has come up a little later, isn't it? And the fever continues now.
It's present for 5 to 6 days after.
So again, it looks unlikely that, see, the fever came a little later. Fever lasted only for 5 days, and fever has again disappeared.
Medication after that, fever has subsided after treatment was initiated.
Discoid lupus erythematosus, DLE, their drug reaction can be acute.
Yeah, so I was in fact thinking of the, as differentials, you have to think of other immune mediated skin problems like You have the Steven Johnson type and all that.
Because it must be a short term, so some toxic reaction. Okay. More than infection induced and even more than autoimmune. So looks like externally injured areas of the skin. And I think she's looking sick also. Okay. She had some fever as well. So I think one of the toxic skin reactions look to be the first possibility.
Only thing is that in those all those Steven Johnson and all, you have a mucosal
Yes, yes.
involvement.
But
And
then there are many other
yeah,
toxic
toxic
reactions.
epidermal necrolysis
Yeah.
and all, the 10 syndrome. In that, there's a big spectrum.
Yeah.
But these are all very discrete lesions. They are not generalized. They are multiple but discrete. You sent you asked for a dermatology opinion. So what did they say?
They told that it is SLE only. DL.
It's the rash.
Rash, they are the opinion that it is lupus related rash only, and they have advised a biopsy also for this one.
So the rash is part of the lupus, you are saying.
And at the previous hospital, her antibody came out to be positive.
DSDNA.
So further workup was not possible there. So they referred her here. So we have done her renal biopsy and sent for light microscopy and electron microscopy yesterday only. So now it is awaited the report.
So which are the organs that are affected in her as of now, according to you?
She has pallor on general examination. So an anemia component is present. Then BP is between 50 to 90th centile. So hypertension is not present yet, but urine output is also maintained. So lupus nephritis, like there are no obvious symptoms suggestive
Not
of lupus.
output, but what about urine routine? Is there proteinuria?
We have sent 24 hours.
Acha, okay, ठीक है, we'll see. Then
her sensorium is maintained, so neuropsychiatric manifestations are not present.
and this weight loss is, so you said she's already been
Chronic.
chronic. Okay. Any hepatosplenomegaly or anything?
Liver 1 centimeter palpable. I could not find lymph node.
Okay.
But the rash was initially much more. After the treatment, it has reduced. Like the parents are only saying, "के आता खूप बरं आहे पहिल्यापेक्षा." Like when she was in other hospital.
So what treatment was given?
Like tacrolimus ointment, then hydroxychloroquine, prednisolone, and sunscreen was advised for preventing photo exposure. We have added antioxidant vitamin A, C, and E. We have added here. Yes.
Okay. Tell us whatever other investigations you've got. घेऊन जा बरं.
Yes, tachycardia also. So that is like inflammatory related, or she's 120, 130 is her tachycardia. So we gave her one PRC transfusion also by 10 kg, but still the like we felt it is due to anemia, but still the tachycardia is persistent. So on presentation, her hemoglobin was 6.6, for which we transfused her. WBC was 4,000 and platelets were 300,000. RFT was maintained 13 by 0.6. Slight like enzyme elevation, liver enzymes 91 by 57 were our OTPT levels. EGFR was 66. CRP was also not raised. ESR was 103. So we have sent her Cox workup, Putam for AFB smear and MGIT.
Yeah. 103.
Yes, sir, was raised. The 24-hour urinary protein was more, 43. So the normal range of this lab is less than 24. So her was elevated, 24-hour urine protein,
43.
43. 43 mg per dl. So multiplied by 10 will 430. And UPCR was 1.8. So renal biopsy is awaited. USG, it was done in the afternoon. So I have not got the report yet.
So just for our learning, have the dermatology people given a description of that rash or what means how have they called it a part of essay?
And they have written, I have not.
Okay, you don't have it here.
I'll share the photo.
And this you said that this child has been chronically malnourished, so that's all because of a poor diet since what
Poor
was the
feeding.
height weight?
Weight was 12.9 kg, so less than -3 standard deviation.
12.9.
12.9. Height was 112 centimeters and BMI was 10.2.
And she's 8 years
8 years.
completed.
8 years complete. Who belongs to lower socioeconomic strata only. They stay in village, so more nutritional related.
Okay.
I think you're right in analyzing it as nutritional, but generally at this age we consider it as secondary nutritional, not primary. And therefore, can we consider that this silent disease is going on for some time? If that is so, then does an autoimmune disorder behave like this? Is another question. Or whether she has something different to account for that kind of a poor nutritional state, and an SLE is the recent issue. So I think we need to really look at all those things. Okay, but SLE has not been there for a long time in this child. So SLE has come up only later, but something has gone on for a long time. Well, primary nutritional deficiency could occur at any age in India. I agree to that. But to that extent, as a rule, we must look at the secondary problems, if any.
We are thinking of Cox also because she's
Yeah, I mean, something hidden, whatever it is, we won't know. Clinically, we have no idea. But yes, this looks like an SLE. I only knew that books say SLE can have any type of skin rash. Butterfly, etc., is not just diagnostic. But we had never seen one like crusting and all that. That looked very unusual. But I'm sure you have proved it. So there is no doubt that this is an SLE. On the background, whether there's something else, we don't know.
So you are looking for tuberculosis, that is fine, it's justified also. But I want you to understand that in your mind, you have to think this way that this child couldn't have been having tuberculosis for last 5 years, which is leading to a weight of 12 kg. You get my point? It has to be a recent event, last 3 months, 6 months, whatever. So in that clinical story, you should try to get that she was better in her weight till six. She's from low socioeconomic, but she's 12 kg. So, if you get a clinical story that she might have been 15 kg 6 months back and then now is 12 kg, then it tells you that in these last 6 months there is some disease, right? So I'm just saying that start thinking like this to get the clinical story together. You understand? So you need to ask, was the weight was bad all the time? She was very thin, but was she better than this a few months back?
When there is so much of disparity in nutrition at this age, one would have also asked whether she was otherwise active, moving around, going to school, playing. If that was so, then that was not nutrition doing it. Whether there is some other cause, maybe syndromic, not growing too well, whatever. Was she born normal, full term? Okay, was she born very preterm? That's why she's still lagging behind all these. But I think when somebody is not doing well for a long time, one should get into details of behavior, activity, energy level. All that would have gone down. If so, then there is a secondary cause. If that was not so, then possibly that was not nutritional issue also. Then why she's so small in weight, height, etc. We will have to look at further on that.
Sir, if you look at her arms, there's hardly any muscle. It's skin and bone, and there is no loose skin, not loose fat. So she has not lost recently. So she has not gained. Her muscles have not developed only. It's just very thin muscles and directly the bones. So she must have not been gaining weight for quite some time. Must have been, but with this poor mass, she could not have been very active.
If there was something that she's born with, she has lost so much of weight in the initial period, she must have been sick, nutritionally or whatever. But if you get a story, no, she used to be normal, going to school, playing around, then we start wondering why she was so small in weight and height and still otherwise doing routine life course reasonably normally. Now, that's the only way we would have confirmed because we won't have a growth chart on this.
Actually,
She
sir,
has brothers and sisters.
she has two sisters, one elder and one younger.
How are they nutritionally? The
Yeah.
younger one?
She has not got both the kids. And I should have asked. I asked की she stays in आदिवासी पाडा. So I asked her की घरातली कामं करते का ती? इकडचं काय सामान उचलून जे सांगेल ते करते का? तर mother said she does it before the illness.
Sir, that also we don't know. तिकडचं काम तिकडे कर म्हणजे काय ते इकडून भांडत तिकडे ठेवत असेल. त्याच्या पलीकडे काय
We don't know exactly what work she.
खेळायला जाते का, थकते का, इतर मुलांच्यावर धावपळ करते का? असं
Okay.
That means that mother must not have said this just because she did something little small. She must have been involved. But I think good that you asked all these questions. So let's see further what you see. Okay. I'm sure the point is even if you treat SLE successfully and controlled it, the nutrition may not improve. Okay, the health state parameters may not improve. Then we will know that. And if she's still active, then we'll know that she's born with this kind of a stature. What the reason, we won't know really. Right? Because we do see infants who are not gaining weight appropriately and are healthy. But we haven't seen such an older child doing that. So that is the issue. Good thing.
Thank you. Online audience, anyone wants to come in? Any comments, any questions? Yeah, so could this be Addison's disease as well because of the pigmentation? But then the pigmentation could be post-inflammatory also. So it's difficult to be sure.
Addison's, it would be only pigmentation, not the rash as
Having sodium, potassium, then which will tell us whether it's Addison's.
complication of SL.
No. Addison, because she's not going well, but vomiting would have been there. And low sodium, high potassium would have picked up.
137 and 3.1. And previously we had repeated it twice. Once it was 134 and 4.2.
And I think she has made a good point that Addison's is pigmentation and not rash. This is the rash.
Another comment is the hyperpigmentation related to chloroquine, HCQ, which was given just recently. So it's not enough time for hyperpigmentation. Correct. Fine. Anything else? Anybody online wants to say anything?
I had a doubt, sir. I have never seen,
One
but
minute. 1 minute. Okay, yeah, come say.
could the rash be related to like pellagra niacin deficiency, or I've not seen it, so because that was
Okay. Fine. If there's nothing from our online audience, then we log off at this point.
Rajesh, just to say thank you to Dr. Amdekar and all the faculty who has taken so much trouble to come all the way, and to the students who have presented two wonderful cases.
Thank
And
you.
thank you,
Thank you,
Pallavi.
Anjali.
Yes, ma'am.
Thank you. Thank you, Anjali. Thank you. Bye. So we
Thank
meet
you.
next Thursday. Thank
Next
you.
Thursday. Thank
Thank
you.
you everyone
Thank you, sir.
online who have joined us.